The broadcast is now starting. All attendees are in listen-only mode.
All right, so we are going to go through this. This is a extra bonus for everyone because I had some technical issues and do not know what happened to the recording from last night's webinar. So we get to hear it again. You guys get to tune in live, which is great. Ian said if you have any questions, you can, of course, ask those, and I will go through those and make sure that everyone gets a great understanding of this topic. So here we go. So welcome to everyone to another EBFA webinar. If this is your first EBFA webinar, then very special welcome. If this is not your first, then thank you for supporting EBFA and all of our education. Do know that all of our webinars are recorded. They're housed on our EBFA YouTube channel, which is youtube.com/EBFA Fitness. And then we also have an online platform for all of our online courses, which this will also be sitting on, which is ebfaglobal.teachable.com. So just know that there's many resources to continue your education through EBFA. What I'm going to do is go through the webinar, through the slides, and then if you have any questions on the topic, then please type those in the questions tab of the control panel. And if you happen to want a copy of this PowerPoint, or you have a question that you do not get answered, please email me education@ebfafitness.com. So we are going to get started with Every Foot Tells a Story, from assessment to application. So this is a topic that is going to be slightly dermatological based. It is essentially what you can determine by looking at a patient or a client's foot as they're sitting in the chair, they're sitting on a table, and you're looking at the feet and seeing, really what is the markings or this quote unquote story from the way that their shoes are fitting, the way that they put pressure through their foot, how they're taking every step, where force is being distributed. And all of that can be easily told through simply looking at the foot. If you are not familiar with who I am, my name is Dr. Splichal. I'm the founder of EBFA Global. I write the majority of our education. I'm also a functional podiatrist and a human movement specialist in New York City. I do still see patients on a super part-time basis just because of several other companies that I'm running. But if you're interested in learning more about my practice, it's dremilysplichal.com, so just my name. And I also do virtual consultations, so that is always an option. If you find that you have a client or patient that you want a second opinion on, please do let me know. I'm also the founder of Naboso Technology, which is the first and only textured 2-point discrimination material that's on the market. And we manufacture insoles and training mats, and they're used for optimizing movement in athletes, individuals who are on their feet all day, children, and people with neurological conditions. Okay, so the goals of this webinar are to help you become a little bit more astute at this story that is being told by the feet. Some of the key areas that we're going to focus on are going to be what's happening with the toenails. Ingrown toenails in the big toe are a huge one that I would see in my practice, and it would tell you definitely a lot more than this is just an issue with the way their nails were cut, or you would blame the pedicurist, which you really can't always blame. Calluses are much more than just dry skin. They tell you the story of how forces are going through the foot and the way that weight distribution is being placed. If we look at the black toenail on the second toe, you see this a lot in runners, soccer, football, dancers as well. Corns are not just a cosmetic issue, and then blisters on the bottom of the foot are not just from tight shoes. So let's get started with our first story that is being told. Sorry if I did not warn you, if this is grossing you out. I could have chosen much more enticing ingrown toenail. However, ingrown toenails in the big toe, let's say you have just one, completely different situation, but it's when you or the patient, the client, has recurring ingrown toenails in the big toe. This could be either on the medial border or the lateral border of the nail. But what I want you to understand is if you can see my arrow, I hope you can, this is the top of the nail. That's actually not all of the nail. The nail actually goes way beyond the outside aspect of the nail. So it actually goes underneath the skin and grows probably a good 3 to 4, sometimes 5 millimeters deep into the skin. So if you imagine that you're taking a step and you're rolling off of the side of the big toe, you could be pushing into that nail underneath the skin and not even realizing it. So anytime a patient comes in and they have recurrent ingrown toenails, I'm going to first look at their footwear, see is it tapered. Imagine a woman wearing stilettos or something like that. That definitely puts pressure on that nail bed. But I'm also going to start thinking of the way that they're pushing off and every step that they're taking and seeing if that's actually what's contributing to this. So you have that client patient with recurrent toenails. You want to ask yourself, are there associated bunion with this individual? If you have a bunion, you know that's going to affect the great toe, the first MPJ, the way that you push off. Is there an associated Hallux Interphalangeal? What is that? I'm going to go into that in one moment to show you exactly what that is. And then, are they wearing narrow taper shoes, like I had said already? If they are, obviously you want to modify that. And then, are they doing a low gear push off? So I'm going to go into that as well. So this is what a Hallux Interphalangeal is. So if you can see my arrow, this is where the first MPJ is on the foot from a clinical perspective. And then if you look at it from an x-ray perspective, this is the big toe joint, the first MPJ. This is actually an issue of the next joint, which is the IP joint. Right here as well, you can see that they're pushing off of the side of the distal aspect of the big toe. So it's not just the entire toe that they're pushing off of, but really the end of that toe. And then that recurrent pressure and force is starting to create an angulation and a subluxation of that joint, which creates a structural issue. So if you see this presentation in your clients, many people will say that this is, or they'll confuse this with a bunion, and then they'll do correct toes and short foot and foot strengthening and all the things that I recommend for patients. And that's absolutely not going to do anything for this client or for this issue. This is now a structural issue, and the only way to make that toe straight, this IP joint straight, is surgery. So you do want to make sure they do not have an Hallux Interphalangeal. Now, individuals who start to get this Hallux Interphalangeal typically have a first MPJ issue. So you will see that they have limited dorsiflexion in the big toe, so they have no choice but to push off of the IPJ, or they go around the IPJ and it starts to create this. So, wrong way, my apologies. So anytime you see that, your next cue should be go to the first MPJ and assess that. Now what starts to happen is you go into a low gear push-off position. You can see in this picture that they're not going through the joint, they're going around the joint, around the toe. A low gear push-off position is considered a quote-unquote unlocked, unstable foot, which you do not want to push off of. That destabilizes not only the foot, but the ankle, the lower leg, the knee, the hip, the back, and then it creates a energy leak all the way up into the glutes. So you can definitely see an association between low gear push-off, underactive glutes, or delayed glute activation. We know that delayed glute activation can lead to knee pain, hip labrum tears, groin injuries, ankle sprains, plantar fasciitis, pretty much anything lower extremity. So you do want to look at that push-off position. This is where you could have the triggering presentation is actually the recurrent ingrown toenails. And that's what I would see in my patients is you can have a patient that comes in, recurrent ingrown toenails, you treat the toenail and then say goodbye to the patient. They come back, 6 weeks later, ingrown toenail again. Okay, you treat the toenail, boom, they leave. And so finally you're like, what the hell is the cause of this thing, right? You have to look at the root cause. And that's what I would do in my patients. So I would be treating gait in an ingrown toenail patient versus just putting a Band-Aid on it, which is really what unfortunately a lot of people do. Now, if you have recurrent ingrown toenails and you're seeing this cause, what could we do? If it's a bunion, you're looking at Correct Toes. It's one of my go-tos for almost all of my patients. Bunion Booty is a great offering as well. That's bunionbooty.com, correcttoes.com. If it's Hallux rigidus, you can use rocker shoes. So I use rocker shoes a lot. Some of the brands that I'll put my patients in are Hoka's, Dansko's, and Reshod. So there's a great shoe company called Reshod, reshod.com. It was developed by a speed walker. So it has a rocker technology built into it for speed walkers, but I like it for patients with first MPJ issues. Wider toe box, of course, get out of the tapered shoes, and then train the foot for a high gear push off. Our next issue that we want to look at is going to be plantar calluses. So this is the next story that is being told by your foot. This is probably one of the easiest to understand, is where the calluses are being formed. It tells you exactly where there is excess pressure on the foot. So our first callus is going to be a pinched callus. A pinched callus is along the medial side of the big toe. You can see my arrow on the medial side of the big toe and then the medial side of the first met head. So calluses on those two positions, how they happen or how they form is that when you are about to take a step, you roll and you pinch the skin between the foot and the ground, hence the pinched callus, and that is essentially formed by a low gear push off. So anyone who's pushing off of their foot like this typically starts to get calluses like this. So that is telling you that they most likely have a first MPJ issue that you need to address and understand that their push off position is not optimal. Now, another one that is similar, it's telling you they have a first MPJ issue, is that you can get a callus underneath the hallux. And this callus underneath the hallux is at the IP joint. So there's a common association between first MPJ problems can eventually lead to a IPJ problem. To an IPJ problem. Now, underneath where this callus is, sometimes you can actually get a sesamoid. So you can have a small sesamoid bone, which if they're putting excess pressure on that joint, you're going to put pressure on that sesamoid, and then that'll obviously create the callus. Regardless of what that causes, if it's the sesamoid or it's the first MPJ, we know we need to go back to assessing the first MPJ, assessing the push-off position. If they have an issue in that first MPJ, we need to address it. If it is arthritis, you need to address that. Are you going to give them a rocker shoe? Are you going to give them a dancer's pad? Are you going to give them a reverse Mortons extension in a orthotic? Are you going to give them a rocker shoe? Are you going to tell them to go do surgery? But you want to find what that root cause is in that first MPJ and have a plan of addressing it. Just doing foot strengthening is not always a correction for first MPJ push-off position lever issues. You do want to make sure that you're ruling out anything structural. Of course, if there's an associated bunion, you want to address the bunion as well. Not every bunion is going to have a restriction in dorsiflexion, but the more progressed it becomes, that is definitely going to happen. Now, the way that you want to start to address this, fix the bunion, correct toes, bunion booty, just like before. If it's hallux rigidus, rocker shoe, just like before, and then train for a high gear push off. I use rocker shoes to do that. Your next callus story that is being told is a callus underneath the second. So if you see this in any of your clients, what that is telling you is that they have excess pressure underneath the second met head or the second MPJ. Now, if you remember, if anyone who's taken my courses in BTS level 1 or Barefoot RX knows that the part of the foot with the highest amount of force is going to be the second. So the midline of the foot is the second. The longest metatarsal in the foot is the second. The part of the foot that takes the highest force is the second. So it's just inevitable that we're going to see or be predisposed to calluses under the second. Now, if you do see this, so it's not normal to have a callus. It's normal to have excess force under the second, but not normal to have a callus under the second. What that means, or what you should start seeing, is if I didn't see the toes, but I saw this in a patient, I would guess that they most likely have a long second toe, which is called a Morton's toe. Long second toes are predisposed to get contractures or a hammering of the toe. The hammering of the toe is because shoes are fitted to the first, not to the second. So if you are in a shoe and you are pushing that second toe down and creating a hammer toe of the second, that creates what's called retrograde pressure. And then the retrograde pressure creates increased force under the second, leading to the callus. What you also want to see, or if I didn't see the toes, I would guess that potentially there is a bunion on this foot, which there is a bunion on this foot. Now, why I would start thinking of a bunion when there's a second met callus is because if you cannot go through the first MPJ, you get what's called transfer stress to the second, which means now we have increased load under the second, leading to the calluses. So we want to make sure that we're starting to balance force underneath the foot. Address the bunion, address the long second toe, and address the excess force. So are you fitting your shoes to the second? If you're not, please make sure you do. If you have repeated stress to the second, you are increased risk to getting a plantar plate tear, which is one of the most common injuries that I see in my office. It's what I specialize in, and I do stem cells for a majority of these patients with plantar plate tears. We go into plantar plate injuries a bunch more in our newest online course, which is the Functional Foot and Ankle. I have a link or an image of it at the end of this webinar. But just know that that would give you a very in-depth, detailed perspective of plantar plate tears. Now, how do you want to address this? If they have a Morton's toe, you want to start properly fitting your shoes. Fit it to the second. If they have a callus under the second, you want to use what's called a U-pad. Just go to Google, enter U-pad. You will see what I mean. It's essentially a pad shaped in a U, hence the name U-pad. And there's an area that is cut out, and that's essentially where you're putting the callus or the second met head. You can also use a metatarsal pad underneath the foot. These are great for offloading and trying to balance force through the foot. And then, of course, you can use rocker shoes. Your next callus story, let's say again, you don't see the rest of the foot. You were just showed a picture of calluses underneath the first, the fifth, and then you have your heel. So think of it like a tripod. Any patient that has a very tripod foot, you should immediately start thinking high arches. High arches typically have this tripod position, and what's happening is that when you get into a supinated inverted foot, which is what a high arch foot is, you actually start to invert the front of the foot. And the way that they balance this is you balance the inversion of the front of the foot by dropping your first ray, and that puts excess load on the first, creating the callus and the tripod foot. So you see tripod foot, you're going to go, moving forward to thinking they have a foot potentially like this. A higher arch, potentially a anterior cavus foot is what you can see. Sometimes tripod feet become what's called a neurological foot. So I actually see this foot type in a lot of my neuropathies, my Parkinson's, MS, CMT, different neurological conditions can start to present like this. Now, you may also see that there's hammering in the digits. When you get all of the digits contracting, what you typically see in the ball of the foot is this. So diffuse calluses that are across the ball of the foot, that's from excess pressure that's being placed on the ball of the foot. Most likely, if you just see the calluses and you don't see the toes, you could guess that they have hammer toes across 2, 3, 4, 5, and that leads to it. One thing that I do want to point out here, here's a fun dermatological lesson. If you can see the small little callus that is towards the fourth toe, that is called an IPK. So it's a special callus, is what I tell my patients. It is a intractable porokeratoma, IPK, which is a corn, not a callus. I'm going to go into corns in a second. It's a corn that grows inward, and some people call them seed corns. They can be very painful. All it means is there's pinpoint pressure in that exact area versus diffuse pressure. So that's your fun dermatological lesson. Calluses and corns will never ever go away unless you take away the force or you shift the force. So paying money at a pedicurist to have them quote unquote treat your calluses and take them away is you're throwing your money away because it's not going to do anything. It feels nice, but it's not doing anything. Okay? So questions that you want to start asking yourself is, does your client have any sort of underlying neurological condition? Do they stand on their feet long hours? What is the understanding of this excess force? And if they do have an underlying neurological condition, of course, you want to address that. And then you want to make sure that you're focusing on foot mobilization, any high arched cavus supinated foot. You want to mobilize the bottom of the foot. You want to make sure that you're mobilizing the soleus, the inverters, the tibialis anterior, posterior tibialis, so that you can get that foot to relax a little bit. Offset any of those pressure points because, again, these are rigid feet. So you're not going to get a lot of changing in that foot type or the foot pressure. You can use orthotics for this. There's a very good material that is used for those with rigid feet or these high pressure points. It's called plastizote is the material. It is like a peach colored material. It is FDA approved for diabetic neuropathy and the uneven weight distribution that we see in a lot of diabetic feet. You can also use what's called a dancer's pad. You can use a met pad, and you're just trying to balance forces. At the end of the day, a lot of what we're trying to do is balance force through the foot, pressure through the foot. Okay? Your next story that's being told is, let's say you have a client or patient and they have a black toenail. As soon as you start thinking of a black toenail, if someone tells me they had a black toenail, my guess is that it would be the second. If they said their second toenail is black, my next guess would be, do they have a Mortons toe, which is a long second toe? My third guess would be, are they a runner, or are they doing some sort of back and forth movement that they're hitting the front of their shoe, creating a microtrauma? And that microtrauma is creating what's called a subungual hematoma. So that black underneath the nail is blood. If it's fresh, then you can actually drain it. I feel like I shouldn't even tell you how to drain it, but now you're probably curious. I'll tell you. Just don't do it at home yourself. Is if I have a patient that comes in, let's say that they just ran a 5K, 10K marathon, and they come to me and they have this subungual hematoma, I would actually take an 18 gauge needle and bore several holes in the top of the nail, and I could drain the nail. You do not want to take the nail off, but you essentially drain the nail. It takes pressure out from underneath the nail, and then typically they heal totally fine. However, if you see this, make sure, just like the Mortons toe, that you are sizing the shoes appropriately. You're sizing the shoes to the second, not the first. If they have a black toenail and a callus under the second, then make sure you're using a U-pad or a met pad. And then if they're a runner and they're doing too much sliding forward and back in the shoe, then I would suggest that you change the lacing on the shoe. All shoes have a eyelet that is higher than the way that the factory laces shoes. So you want to actually lace all of those eyelets, and it prevents the foot from sliding forward in the shoe when you are running or thinking like CrossFit and stop and go type movements. You want to do that last eyelet in the shoe. And then that can prevent the foot from sliding forward and back. Okay. All right, your next story that you are hearing or seeing is corns. Corns are different than calluses. Calluses are typically on the bottom of the foot. They're diffuse pressure. Corns are from more of a finite pressure. So you see corns on the toes. You can see that these are pre-corns that are on the toes. I wouldn't even call them a true corn, because if they came into my office, I wouldn't be able to shave or debride any skin off of them. So they're a pre-corn. This pre-corn, patients typically come in aesthetically not liking them. But let's say that's how they're presented, and you say, oh, it's because you have hammer toes. And they're like, no, I don't have hammer toes, right? They look fairly straight, these digits do. What I want you to start thinking that the story that's being told is that this patient or client has what's called dynamic hammer toes. These dynamic hammer toes means that when they are walking, every step that they are taking, their toes are contracting in and buckling, even though you cannot see them because they're in the shoes. That is what's happening. And because that's happening in the shoe, it's hitting the shoe, creating pressure, and then that is creating these corns or these pre-corns. So that story is starting to tell you, you need to look at dynamically what is happening to their toes during gait. There's two functional or dynamic hammer toes. First one is called extensor substitution. This means that the extensors in the front of the foot are dominating the smaller muscles in the foot, and it is creating contractures during swing phase. So as the client picks up their foot, their toes are contracting inward, creating the hammer toe, and then they place their foot down and the foot relaxes. Now, the opposite of that is a flexor stabilization. This means that their flexors, long flexors, are dominating the smaller intrinsics, and every time they go into a push-off position, the hammer toes contract, and they get that dynamic hammer toe with every step that they take. So whether it's happening in push-off or it's happening in swing, it is happening every time they're taking a step. Imagine that's 10,000 times a day. That is obviously going to create imbalances and these corns that we're seeing on the foot. So how do you start to address that? I like to address that by using correct toes in every single one of my patients that has hammer toes, whether it is structural or functional or dynamic or rigid. I recommend the correct toes. You want to create muscle balancing and intrinsic strengthening. So if it's a extensor dominance, obviously release the extensors, try to strengthen the intrinsics. If it is a flexor dominance, mobilize the flexors and strengthen the intrinsics. If they have narrow shoes, try to go to a wide-toed shoe. This could be any of your favorite natural shoes, Zero shoes, Vivo Barefoot, Ultra, it doesn't matter, whatever brand you are particular to. But make sure you're giving the shoe or the foot space. Now, our final story that is being told is blisters. If you see blisters on the foot, the cause of the blister is different than the calluses. Remember, calluses are diffuse pressure, corns are finite pressure, blisters are friction. Blisters that are happening on the bottom of the foot, such as on this hallux or on the big toe, are not because of tight shoes. It's because of the movement pattern of the client. So you want to start thinking, what is happening as they go through the big toe, which is push off? Are they doing some sort of movement that is creating friction? Now, typically what you're seeing is what's called a cigarette twist. Now, a cigarette twist is that you're spinning the foot. Imagine you're putting out a cigarette, right? So you're twisting the foot like that with every step that you take. That's a common imbalance when you have limited ankle dorsiflexion or limited first MPJ dorsiflexion. You can also see it with tight psoas. So different reasons of where a client may potentially spin their foot out to get around the ankle, the big toe, or the hip, and then that creates the friction, and that is one of the most common causes of blisters underneath the hallux. You want to look, do they have ankle restrictions, first MPJ restrictions, hip restrictions, and then you want to address that. And then they really could also have excessive sweating in the feet, which is making them a little bit predisposed. Just having sweaty feet and normal walking does not create blisters, so they still have to be doing some sort of extra movement or compensation when they are taking a step. So you do want to make sure that you are addressing that. So how do we want to start addressing these? Is that you want to look at that range of motion, address that range of motion. You want to address any of that excessive sweating if you would like. There's tons of great ways that you can do this. One of my kind of home remedy ones is you can soak your feet in tea, which shrinks sweat glands, and then address sliding in the shoe. So potentially if they are a runner and they're sliding forward and back because of the lacing, that's where I had said you do want to change the lacing so that their foot does not slide forward and back. Now, as we wrap up, I want to give you a real quick example or story of how I had seen blisters. It's just a patient that I remember quite vividly who had these blisters in her feet, and she would have blisters underneath the hallux and then along the first met head. So almost where you would get pinched calluses, she would get these huge, really bad blisters and sometimes blood blisters every time she went running at the gym. And she had seen several other podiatrists for it. It was still a recurrent issue. And she came to me for just another opinion on it. She had really bad blisters. She's saying, I get this every time I run, and then eventually they pop, they dry out, and then she goes running again, say 5 days later, and then the exact same thing happens again. And then they pop, they dry out, she goes running 5 days later, and she's just like, this is ridiculous. And she said she even thinks it's the shoes, and she got new shoes, and she keeps buying new shoes. And her recent shoes, she had a pair, kept thinking it was a shoe, would take them back to the running shoe store. I remember it was here in New York City. She was taking it to Jackrabbit and would say, I think these are the shoes. We have to switch these shoes. And they're like, yeah, maybe it is the shoes. I don't know why you're getting blisters. So they'd give her a new pair of shoes. And then she'd still get the blisters, take them back to the shoe store. It's still the shoe. I think it's the shoe. They'd say, I think it is the shoe. They gave this girl like 6 pairs of shoes because they just didn't know how to address it, not realizing that it wasn't the shoe, it was the movement pattern. So prior, every podiatrist would drain the blister, not de-roof it, right? So keep the skin on the top, drain it, dress it, and then say, okay, here you go. That's how you take care of it. She'd come back, they would drain it. So they were essentially treating or putting a Band-Aid on the issue. It was not until I saw her that I was like, this is not normal. I need to see the way that you're running. So I took her to the back of the office where we have a treadmill, and I said, I need you to show me exactly how you run. And she said, when I'm at the gym, I put an incline on the treadmill, put it at like a sprinting, 10 miles per hour type sprint. So she's doing like a 6-minute mile. And she goes, I hold on to the TV monitor and sprint. And I'm like, what the fuck? Like, no wonder this she's getting blisters. So I'm watching her run exactly how she's running in the gym. And the belt is moving so fast. She's putting her foot on the ground and the shoe is trying to keep up with the belt. So you have friction between the shoe and the belt, you have friction between her foot and the shoe, that it was no wonder that she would get these massive blisters. So instead of just treating the blister, draining it, and keeping the roof on it, I instead changed her running pattern. I got her to slow down, stop hanging on the TV monitor, actually get into a proper running speed that you can control, and ideally off of the treadmill if we can. Of course, all of her blisters went away. So this is where I hope that understanding the story that is being told by the foot helps you to help your clients or patients in a way that maybe they have not heard yet. Instead of just treating the symptom or putting a Band-Aid on it, is actually looking at that root cause and addressing how the movement pattern is creating the ingrown toenails, the corns, the calluses, the blisters, or the black toenails, and how we as movement specialists can correct those movement patterns. If you have any questions, please do let me know. If you are interested in taking one of our trainings, we're actually doing a training coming up, a level 1, level 2 combination. This is through Body, Mind, Learn in Chicago, or just outside of Chicago. So please do check that out. If you are not in the United States and not traveling for a myriad of reasons, Please do check out our online education. This allows you to continue your education without the traveling inconveniences. This is one of our newest courses, Functional Foot and Ankle. This is found on ebfaglobal.teachable.com, and it is a 6-hour intensive, very detailed foot course. It's one of the most detailed that is going to be available, or that is available, looking at forefoot, midfoot, and rear foot. And then if you're looking for the integrated approach to the foot, that would be our BTS level 1. This is also available online. So if you cannot attend one of our courses or certification in person, please know that our BTS level 1 is available online. This is on ebfaglobal.teachable.com. That version is essentially a video of me teaching a level 1. So you get to hear some of the questions, you get to see the assessments. It's a great way for you to experience the course without the traveling. If you have any questions, please do type those in and I will go through those. If not, please do remember to follow us in all of our upcoming webinars that we're doing. Please follow us on social media, EBFA_barefoot education. Thank you all so much. Have an amazing day or evening, depending where in the world you are. And I will see you on another EBFA webinar.